afternoon and welcome everybody. Good afternoon, Barcelona too. Welcome everybody to this second event within the Liver Seminars program, which is really a very attractive learning activity, and we hope that the successful of this activity really relies on everybody's input and everybody's efforts and the capacity of putting together our common thinkings and works together. Yeah. So let's move to the topic of today. Today's topic is acute and chronic liver failure, ACLF. This is a recently described syndrome which is highly prevalent on hospitalized cirrhotic patients, and it has a high mortality. And it was obviously, that there were reasons important enough to bring this topic here for discussion. The invited speaker is Professor Rajiv Jalan, that I had the pleasure of joining his group in London a few years ago, where I really had a great time in terms of science and in terms of the people I found there and the support and the friendship I found there. I don't think that Professor Jalan really needs an introduction. I think he's really well known in the pathology field. He doesn't need it, but I'm going to do it, very short one. So he's the editor-in-chief of the Journal of Hepatology. He's professor of hepatology in the University College of London, and he's truly an expert on the topic of today, on ACLF. He made many and important contributions to the description of this syndrome, to a better knowledge on the pathophysiology, on the epidemiology, and on the development of potential new treatments. So I think we are really grateful to you for accepting this invitation, for being here today to update us with the more recent data about this important syndrome. And we are so grateful to you, as I said, and please, this is the time for you to give your talk.
Well, thank you, Rita. Thank you for this very kind invitation, Rafa. Thank you, Ismail, for this great welcome. And I feel a little bit envious coming from London on a sort of beautiful day, sunshine, everything else, with a room full of people willing to hear about a liver story. So liver seminars, I think, is a fantastic idea. And I say hello to my friends in Barcelona who I know are hearing what I've got to say. So this is, like I said, a very relevant topic, and it's not, this is not a term that I understand that many of you are not from the liver field, but I just hope that I can take you through the journey of what this is. These are my disclosures, and these are very relevant because I'll be alluding to some of these different potential treatment options for this condition as we move forward. During my study, I discovered many things, and that's led to the development of a new spin-out company from my university, which is developing some of the inventions that I'll talk about. This is a drug I'm not going to describe today, but is now entering into phase 3 clinical trials discovered at UCL. So this is what I'm going to focus on. And we'll talk a little bit about the definition of ACLF. I understand that many of you don't know what I'm talking about. I'm going to focus a lot around cell death, and which I think is an increasingly important concept in the pathophysiology of this syndrome. And then I'm going to introduce this idea about the ACLF spiral and why it is so important to try and interrupt with it if you're going to make any difference to the outcome of these patients. And then finally, show you how I'm thinking about this syndrome, where these new treatments are going to come from, what are the relevant potential biomarkers which might help us with stratification, but of course with better understanding of the syndrome, companions to new therapies. I'm sorry, this is a little bit complex slide, but this is important because I'm trying to illustrate to you the syndrome we're describing. So this syndrome happens in patients with cirrhosis, patients with underlying liver disease. this is how we see the syndrome. So there's a pre-cirrhotic disease which lasts for anywhere between 10 and 35 years. So patients who drink too much, have got viral hepatitis, or have got alcohol abuse. Too fat, alcohol, and virus, three main cause of pre-cirrhotic disease. And over this period of time, patients will develop cirrhosis, and they will stay in a state of compensation for anywhere between 3 to 5 years, 5 to 10 years. And 50% of patients with cirrhosis who are compensated will develop an episode of decompensation within about 5 years, and another 50% of them will die within the next 5 years. So this, I think, about 20 to 40-year landscape of liver injury to death. And this is the concept that has existed with us for a long, long, long time. By decompensation, we usually refer to these major complications: the occurrence of ascites, variceal hemorrhage, brain dysfunction, encephalopathy, or bacterial infections. The 4 cardinal features of the decompensating event. What we're going to talk about today for the most part is this syndrome, which we call acute on chronic liver failure, which can happen in any of these patients here. So any cirrhotic patient can go directly from being compensated to development of acute on chronic liver failure, and the difference as to why this of acute on chronic liver failure from decompensation is what I'm going to talk about in the initial part. And to introduce to you the idea that the transition of this patient from compensated or decompensated stage to an acute on chronic liver failure stage creates an environment which leads rapidly to death if you do nothing about it. And this syndrome is characterized by the occurrence of organ system failure. So here is decompensation, here is organ failure, and we start to introduce into the definition the occurrence of extrahepatic organ failure, defining the risk of death: kidney, brain, coagulation, cardiovascular, respiratory, in a patient in whom liver is dysfunctional. So really important concept. So acute decompensation as a part of decompensated cirrhosis, but acute on chronic liver failure can happen to any patient with cirrhosis, with or without a defined precipitating illness. So conceptually really important. In simple words, this is what it is. It is acute deterioration of pre-existing chronic liver disease, usually related to a precipitating event and associated with increased mortality at 3 months due to multi-system organ failure. This was the hypothesis that we have put meat on that bone, and it was based around a very large study that we were able to do in Europe, with about 30 European centers participated. We agnostically studied nearly 1,500 patients who were admitted to the hospital with an acute decompensation of cirrhosis to come up to define as to whether this was indeed true or not. What we came up with was 2 things. The first was we defined up front and based upon the data that when these 6 organ failures are associated with increased risk of death. In a patient with acute deterioration, if the bilirubin was greater than 12, it was associated with a condition which we called liver failure. If the creatinine was greater than 2, then it was kidney failure. If patients were grade 3 to 4 encephalopathy in coma or pre-coma stages, they had brain failure, coagulation failure. If their INR was greater than 2.5, if they required vasopressors to maintain mean arterial pressure greater than 70, they had circulatory failure. And if their PaO2 to FiO2 ratio is low, they were defined as having respiratory failure. So these are patients with cirrhosis that have acutely decompensated, come into the hospital. These were found as independent predictors of mortality. All right? And the presence of either kidney failure or any other organ failure with mild kidney dysfunction and mild brain dysfunction constituted acute on chronic liver failure. Now this is important because the occurrence of ACLF clearly demarcates the risk of death. So here is your patient with acute decompensation, no organ failure. 28-day mortality in the blue is very low. But if you have organ failure as we have defined, then their mortality rate is nearly 20%. Very clear distinction in risk stratified groups. That is, a patient, if they've got 2 organs that failed, 30% mortality. If 3 or more organs have failed, the 28-day mortality is nearly 80%. A very clear demarcation of a patient with acute deterioration that you cannot identify otherwise. If they've got 1 organ failure or one or more organ failures, increasing risk of death at 28 days. And this was where the hypothesis was fulfilled, that an acute on chronic liver failure patient is distinct, at least in prognostic terms, from a patient with acute decompensation of cirrhosis. And this is important to understand. And this is really the culmination of a huge amount of work done by many people to come up with this distinction. Clear prognostic group differences. This is a slide which is again a little bit complex, but I want to take you through it because it talks to why we should focus on this group of patients. Why is it so important to recognize this syndrome? And it illustrates the idea of reversibility of this syndrome. So I showed you in the first slide mortality. In this slide, what I'm trying to show you is that if you are there and you can do something about it, you can make a real difference to the lives of these patients. So look here. So what we have got here is, here are the 3 groups of patients: ACLF1, ACLF2, and ACLF3. If a patient with ACLF1 progresses to ACLF3, their mortality rates are like that of ACLF3 rather than like that of ACLF1. But if I can turn this patient back to having no ACLF, their mortality rates are like that of a patient with acute decompensation and not like that of ACLF. A patient with ACLF2 has a mortality of nearly 29.6%. If I can convert them down to no ACLF, their mortality is 2%. There's a real opportunity to intervene, because if we intervene, we can get them back to the state they were in. We can reduce their mortality rates. Remember that an ACLF3 patient had over 85% mortality. In this situation, 96% mortality. If we're able to turn them back, the mortality rates are like that of a patient with ACLF1. So early recognition, and if we only had the treatments, then we can change them back to where they were. So the point is about reversibility of this potential syndrome. If you can get them to 28 days, it's likely you'll get them to 3 months. If you get them to 3 months, if you can't get them better, at least you'll get them an organ for transplantation. So think about reversibility. The syndrome is important because it clearly identifies a different group of patients. What it also does is to identify that this syndrome is not a death knell. It has got potential for reversibility. So we've now spent nearly 7, 8, 10 years trying to understand this syndrome, to see what we can do to start to take these patients here and turn them into having no ACLF. And that's what I'll focus on for the rest of the talk. So if you want to develop new treatments, which is what I want to do as a clinician, which is what I am, we need to find good prognostic markers, good models, good patients to select for therapies and treatments, trials, etc. And in order to do that, we generated a new score. It's called the CLIF ACLF score. And I'm not going to go through the whole palaver, but it's looking at all the data and doing straightforward but very high quality statistical test with knowledge. And we came up with a combination of organ failure score, which I've already shown you, age and white cell count as the 3 independent predictors of mortality. We put it into a mathematical model, which you can download if you want, an ACLF calculator, and that gives you a prediction of outcome of nearly 75% accuracy to predict 28-day and 3-month mortality. But of course, 75% is not good enough. And here's an opportunity for each one of us to find that new biomarker that will improve the prognostic ability. You find a new companion biomarker, and therefore this story will, I think, run and run and run. Huge opportunity, but at least we have something to start with. Just to show this to you in another way, why this is so important, because this underlies why we have no treatments in this condition at the moment. Here is a CLIF ACLF score, which is a score from 0 to 100, and here on the y-axis is the probability of death. This is looking at the same data in another way. And what's interesting to note here is it's not a linear scale. It is, so if you were down here with a score from 0 to 30, the mortality is very low. And if you're up here, you know, you have a mortality of nearly 90%. So therefore, if you're thinking about developing a drug, if you include these patients down here and survival is your endpoint, you'll need thousands of patients to show a difference. If also you included patients up here, and Rafa will tell you that this is the graveyard of devices, and because including these patients who are really sick with very high risk of death, you're going to destroy any drug or device you're trying to develop. So if you want to develop a drug or device, what you need to focus on is this group of patients here, because it's likely that you can make a difference. And this is a score between 35, 65, clinically available. You can calculate this at the back of your phone. So CLIF ACLF score, a prognostic score which can help you design clinical trials and determine which patients you want to include in what study. This is again a slightly complex slide, but this is important to illustrate why this score is better than any other scoring system that we have that is clinically available to us. And here what I've done is to compare the performance of the CLIF score versus the MELD score. MELD score is what we use for organ allocation even today. So that is the main scoring system which allows us to allocate organs to our patients. What this slide is trying to show is that if we used the MELD score, we would misallocate organs. In about 10 to 15% of patients will be underestimated in their risk of death. So here are the data. So what you have in the red is a CLIF score on the MELD, and the MELD score here, these are very sick patients, okay? What this shows is that the high CLIF ACLF score, if you in the orange, as you can see here, this is patients with CLIF scores that are very high. They can still have low MELD scores, underestimating the risk of death. But none of the, if the MELD score was high MELD score, low ACLF score is associated with, there are now no patients with high MELDs and low CLIF ACLFs defining the risk of death. So therefore, the point is that traditional scoring systems underestimate the risk of death of patients. So therefore, this is a new group of patients which the old scores are not able to identify the risk of death of. So CLIF ACLF score defines this prognostic ability in patients with ACLF. But as you might have realized, I'm talking about a complex syndrome which may have complex outcomes. Some of the patients may get better, some of the patients may get worse. And so liver transplantation is of course a potential option for treatment, but the dilemma is here that we can have three groups of patients, and this is what I've suggested to you. There are some patients that will deteriorate, develop ACLF, but will improve. And these are patients that do not need a transplant. And I can tell you that we do not have the ability to identify these at the moment. These are patients here who, if whatever you do, they will die, ACLF patients, and the only way to make a difference is to treat them potentially with an urgent liver transplant. And here's the third group of patients that have got this ability where they'll improve for a while, giving you a window to intervene, to transplant them. So therefore, these patients do not need a transplant. The ones in the black, in the red need urgent transplantation, and the blue need regular transplantation. And the challenge really for the community at the moment is to identify which patient going to be transplanted, which patient is not suitable and does not need. But suffice it to say that if you take patients with ACLF grade 3, and this is what this French group have recently published, what they show is that if you take these patients with a predicted mortality of 80 or 90%, you don't transplant them, the survival is about 8%, 30-day survival. If you transplant them, you can achieve survival rates of over 85%. Unbelievable. And as you can see here, that depending upon what the ACLF classes were, the mortality rates are not different to those with no ACLF, ACLF 1, 2, or 3. So you can take these very sick patients, if you can identify them early enough and transplant them, you can achieve survival rates which are fantastic. Early identification, transplantation, but now we think about futility, is which patients are too far, too sick to transplant, and we do not have that knowledge at the moment. So this is the clinical side of the story, where I hope I've shown you that ACLF is a real syndrome, is distinct to acute decompensation. We have a reasonable prognostic score which we can help to select patients for trials and prognostication. Transplantation is possible in these, and we can improve significantly the survival of these patients with liver transplantation. Now I'm going to shift gears now from the clinical side to start to talk a little bit about the biology as to whether this clinical syndrome is also different from the pathophysiologic perspective, and whether that tells you anything new. And this is a very old slide, and I purposely have kept this in because this is still true. We think what's going on is, here's a cirrhotic, and the cirrhosis over 30 years is imparting a certain susceptibility to the cirrhotic patient. They get an insult. We think that the central story here is altered host response to injury, and I'll show you this in the next slides. And this is the basis of development of multi-organ failure, and for today I'll just focus on the liver and the brain. I'm not going to talk much about the kidneys, and I will focus a little bit about inflammatory response, immune system, and discuss with you how pathophysiologically this syndrome is likely to be different. From the canonic study, we were able to identify a really important finding, and this is a really important slide because it illustrates a pathophysiologic principle that I've never seen before. What it showed here in the y-axis is probability of death at 28 days. On the x-axis is leukocyte count, simple white cell blood count, not fancy facts. What it shows is if you don't have ACLF, whatever your white cell count, your mortality rate's very low. But if you have ACLF, then the risk of death increases with increasing white cell count. Simple. But what is very intriguing is, and I don't think that we understand this, and that's why this title here on the slide, that the patients that were previously completely well, the well-compensated cirrhotic, has significantly greater risk of death compared with the patient that was coming into the hospital with repeat admissions with decompensation, with the same white cell count. So if you're previously well, not known to the community, never been to the hospital before, with cirrhosis, but you have ACLF and your white cell count is high, the risk of death is higher compared with a previously decompensated patient. Talking about this whole idea as to whether previous decompensating events provide some sort of organ tolerance to the injury that you're sustaining. So important idea. We heard some stories about tolerance this morning. So this is looking at the same data in a little bit more detail. So we did a huge number of cytokine analysis chasing this whole idea about systemic inflammation driving the story. But the story becomes more complex. So here is the traditional hypothesis that we have had in the liver field for the last 40 years, where we believe that organ failure was a result of circulatory dysfunction, splanchnic vasodilatation, renal vasoconstriction, increased activation of renin-angiotensin system. As you can see, plasma renin concentration, which is a sort of a surrogate marker for circulatory dysfunction, is higher. But what is very remarkable is that both the pro-inflammatory and the anti-inflammatory cytokines, IL-10, IL receptor antagonist, TNF, IL-8, etc., are all markedly elevated in those with ACLF. Okay? So systemic inflammation, but compensated anti-inflammatory response is also evident. Now let's look at what happens as you move through the severities of ACLF. Now I'm going from ACLF 1, 2 to 3. The first thing is that this syndrome is not recognized by circulatory dysfunction. Traditional hypothesis is that it is circulatory response, inflammatory circulatory dysfunction which drives organ failure. Unlikely to be correct, but what you see is a stepwise progression in the cytokine profile as you move from 1 to 2 to 3. But it's not only an increase in the pro-inflammatory cytokines, but also an increase in the anti-inflammatory cytokines. And this is important. I'll come back to this as I describe this story a little bit further. So, inflammation is the key to the story. However, I don't have time to show you the data, but there's some beautiful studies here over the last 10 years or so, which have studied patients with ACLF and have started to describe a syndrome of immune failure in cirrhosis. So these patients, although they have this systemic inflammation, very high circulating cytokines, but what they also have is evidence in whichever cell line you want to look at here. Monocytes, there's PD1, MERTK, monocytes, these are neutrophils, there's our study early on, there are PBMCs. So any cell system you want to look at, there's significant immune failure as opposed to pro-inflammatory state when you hit severe organ failure. So the question is whether this is relevant. Is this relevant? You got immune failure, so what? And this is a really nice study from Javi Fernandez based upon the data that we generated in the Canonic study. What he shows very nicely, I'm not sure it projects very well. So this is describing rate of infection during follow-up. And here is an AD patient, ACLF 1, 2, and 3. Now as you can see, as you move through the severity of ACLF, the risk of developing a new infection is significantly greater. It's the same thing here. No ACLF, ACLF, probability of infection increases significantly in an ACLF patient, and this is associated with increased risk of death. So immune dysfunction underlies the risk of a new infection in a cirrhotic patient with ACLF compared to AD, and again suggests the idea that this altered immune function in some way is contributing to this phenomena. So remember, now we've got a pretty complex situation. What you've got is a patient who's come into the hospital with cirrhosis, they've got organ failure, the kidneys are not working, the liver is not working very well, immune system is not working very well, they have increased risk of a new infection. So it's a pretty serious situation. What many people over the last years have done is to look at many biomarkers in this area in order to try and understand what this syndrome is, how it is working. And so I don't really have time to go into this, but I think it may be useful for you guys to have this slide if you want it. I'll just show you some data from Pere Jeunesse, who has been interested in kidney dysfunction for the last 25 years. But he's described some new data in relation to NGAL, which is important. So NGAL, as you know, is a protein which is produced, we thought, predominantly by the neutrophils, but we also know now that during ACLF it will be expressed in the liver, and we also know that it is expressed in the kidney. And the question here was, can we use this marker of, so to say, inflammation in the plasma to improve the performance of the CLIF score? And what he showed very nicely here again is that patients with ACLF have significantly higher values of urinary NGAL and plasma NGAL, which is a test that you can buy off the shelf, significantly higher values. And what he went on to show was that when you add it to the CLIF ACLF score, you can get a significant improvement in the ability of the CLIF ACLF score to predict the survival of patients. So here is sort of add-on phenomena, but it also may indicate a biomarker that not now, maybe in the future, is possible to use to intervene for these patients. Watch that space. So just coming back to this story, and I just want to show you one or two slides to illustrate really what is going on in the organs. And I'll talk a little bit about the brain, and then I'm going to talk a little bit about the liver. So this is the work of the late Juan Cordoba, who you all know is probably the most famous encephalopathy doctor who we lost a couple of years ago, tragically. But before he passed away, he produced this data, which illustrates a few really important phenomena. So we're looking at survival of patients with hepatic encephalopathy. Again, data from the Canonic study. What it showed very nicely was that in patients with acute on chronic liver failure, with no acute on chronic liver failure, if you had encephalopathy, the mortality rates were significantly higher. So brain dysfunction adds to the risk of death in a patient with ACLF. With no ACLF, but if you had ACLF, this substantially increases the risk of death if you've got additional brain dysfunction. I'm not sure how many neurologists there are in the audience, but we now start to think about encephalopathy driving immune failure. And we now have lots of really nice data which starts to suggest that brain dysfunction can lead to immune failure, and the hypothesis is out there for people to test to see as to whether encephalopathy increases the risk of death through immune dysfunction. I don't have the data. But what we were able to do was to replicate this human experiment in the animals to ask as to what is going on in the brain that is different. So we made a model of acute on chronic liver failure where you give animals, you ligate animals bile duct, you treat them for 4 weeks, and then you give them LPS to recapitulate ACLF. And what we showed was that a bile duct ligated animal given LPS gets brain swelling, which also happens with LPS alone, but these animals become comatose. And they become comatose, we think, because of increased nitration of brain proteins. Here is the EMs. This is a bile duct ligated animal. What you see is a constricted blood vessel in the brain. That's a sham animal, normal blood vessel, constricted blood vessel, but which is now completely collapsed. So the brain we have gone on to show is very hypoxic in this situation. And what you can also see here is a very markedly swollen astrocyte. So the brain is swelling, the brain blood vessels are collapsing, and they're starting to nitrate proteins in the brain, which is significantly different to this animal here that it doesn't have, that's got only decompensation with ascites. So brain pathophysiology is completely different in the context of ACLF compared with acute decompensation. Okay, so just moving on. So if you look at the kidney, I can show you the same slide. That is, the kidneys have now shown evidence of acute tubular necrosis, damage, increased evidence of cell death. But I'll come back to that as we move forward. So how are we going to manage these patients? And this is the key for a clinician like me. You know, we want to treat our patients better. So for those of you who are still with me, you realize that this is not easy. This is complex. And what we're dealing with here is a predisposition. which is, what is the etiology of liver disease? Is the patient compensated or decompensated? What is the age of the patient? We are dealing with injury. So the injury here is infection, superimposed alcoholic hepatitis. Patient may have had surgery, they may have had trauma, they may have had bleeding, etc. We're talking about response. The patient may be pro-inflammatory, or they may be anti-inflammatory at risk of infection. And then there are organs. The patient may present with brain dysfunction, maybe liver failure, maybe kidney failure, etc. So it is worthwhile thinking about this syndrome in this sort of context, which I call the PYRO concept, which is not original. I borrowed it from the intensive care world, to allow you to break this patient down into these different components so that you can start to think about targeting one and the other. What I'm not going to talk about is management of the predisposing illness, management of the injury itself, such as the bleeding or the infection or whatever. And I'm going to focus really on the latter part of the story. And this is a sort of the hypothetical paradigm that we drew up to create a framework whereby we can start to generate new therapies for these patients. This is how I see it. There's cirrhosis, and the central story within this, we think, is bacterial translocation from the gut, which together with ongoing cell death is what is leading to organ priming. And so making the organs susceptible to the second hit. So this is really just a hypothetical paradigm. So when they get an insult, there's significant and severe hepatic inflammation, which is associated with increased risk of cell death, further increase in translocation. When cells die, there's further increase in translocation. There's release of DAMPs, damage-associated molecular patterns, from the dying liver. We think the toll-like receptor 4 or other inflammasome pathways are important in driving this syndrome, which then leads to a cytokine cascade, hepatic, extrahepatic organ failures, and then this is self-perpetuating vicious cycle of which is what we call the ACLF spiral. So how the hell are we going to deal with this? This is complex, this is huge, this is, extending across the board. So as a clinician, we take small chunks to see whether we can start to dissect this story apart. What about hepatic inflammation? So this is a failed experiment which we were very interested in early on in my life, where we treated patients with acute alcoholic hepatitis. Many of them had ACLF, with anti-TNF. We found some really good responses, very highly selected patients early on. The French did a controlled clinical trial and showed that the patients treated with infliximab in this situation had higher mortality compared with controls. So there we go. This is out of the window. So using a thunderbolt like infliximab in this situation is unlikely to be useful. What about cell death? So we think this is important because, and this is the missing piece in a way, and we've spent some time trying to understand what is the mode of cell death and what can we do about it. We thought it was all apoptotic, but we don't think it necessarily is, and I'll take you through this. So we start with the liver biopsies. That is where the action is. And is there something in the liver biopsy that we can identify that can tell us what's going on? It doesn't actually. If you do very simple staining, and that's what we did here, these are data from our friends in Belgium, Frederick Neven's group. What he showed was that if a patient had ACLF, their mortality was significantly higher compared with controls. And what he found in his studies was a very marked increase in cholestasis. Canalicular cholestasis was a feature of this syndrome. These are studies from our studies which we did, and we found that there was this balloon degeneration, which was a critical feature of the patients that were unlikely to survive. And this is the This is the stuff that we took forward. And we were able to identify later on through other studies that this canalicular cholestasis possibly represents superimposed infection, but this needs to be further studied as to what this means and what the story is. So we took the story about so what is going on in the liver. Here what we've done is taken patients with alcohol-related acute decompensation, no ACLF or ACLF. But to look at another etiology, we got some patients with hepatitis B acute decompensation, and here are patients with ACLF with Hep B reactivation. So here the predisposition is alcohol, superimposed factor is acute alcoholic hepatitis. Here the predisposition is Hep B, the precipitating factor is reactivation. What we found is, these are tunnel stain, as you can see, the very, very, very severe evidence of liver cell death, which is partly apoptotic, but it's likely that they're partly necrotic, so it doesn't distinguish between the two. So look at this further. We got the samples from the Canonic study. There's a big data bank, and we measured this marker, which is the M30 component of cytokeratin 18, and here is the M65 component of cytokeratin 18, which represents non-apoptotic cell death. And here is an apoptotic index, which is a ratio. Okay? What we found was this. Here are the healthy volunteers, and what you can see is the patients who are decompensated have very high levels, but if the patient has ACLF, then the severity of cell death is very, very markedly elevated. But what you also see is that there is no ACLF. The main mechanism of cell death seems to be apoptosis. But in those with ACLF, the main mechanism of cell death is indeed necrosis, non-apoptotic, maybe paroptosis, maybe necroptosis, but it's not necessarily apoptosis. So pan-caspase inhibitor in this situation is unlikely to work. And this just shows a relationship between the many cytokines that we have measured and its relationship with these markers. As you can see, that there is likely to be a good relationship between these. But this also explains why this study that we recently finished but not yet published, Americasan, which is a pan-caspase inhibitor, we took it to patients with ACLF and really showed no effect in outcomes, because the mode of cell death that I've described to you is likely to be necrosis or non-apoptotic cell death. We measured M30 component here. Although you can reduce the M30 component giving them this drug, it has absolutely no effect on liver function or organ function. So we need to think about something else, a negative study. Okay? What we also found, and this is interesting for those of you who are interested in the pathophysiology, when you're doing transjugular biopsies, you can measure portal pressure, liver blood flow using indocyanine green. This gave us some clues as to what may be going on. What we found was, here in the blue are the patients with acute and chronic liver failure. Here are the decompensated cirrhotics. Here are the well-compensated cirrhotics. What you can see is that as this syndrome develops, the portal pressure goes up and yet the blood flow falls. That means that the resistance in the liver is increasing without an increase in blood flow. All right? And this gave us a clue to ask the question, why is this the case? And this starts to talk to intra-organ crosstalk, which means that, and the hypothesis here was that this may be because these dying cells are releasing something that may be activating the stellate cells, which is what is the main driver of increased portal hypertension. But before I go there, there was this paper that appeared, Americasan reduced portal pressure in patients with cirrhosis. Again, so proof of concept that reducing cell death in patients with AD might reduce portal pressure, which was the first ever. So, coming back to the same story, that the cell death, is it possible that this spill of markers of cell death might drive organ dysfunction? We measured it in patient genomic DNA or histones, significantly increased in ACLF patients. And as you can see in the animal models, if you give them LPS, they spill huge amounts of genomic DNA into the plasma. The question is, what does this genomic DNA do to stellate cells? So we took some human hepatic stellate cells, incubated with these cells. It's very clear it activates them. So we thought, can we find something that can bind these nucleosomes, so that if we can have something that binds it, we might prevent secondary cell death. And this is what we did. Here's a far western showing that albumin, circulating albumin, is able to bind genomic DNA. And when I repeat this experiment in presence of albumin, that's what we show. We protect these cells from activation, and we reduce portal pressure, as you can see here. So here are sham animal, bile duct ligated animals. With albumin, you can reduce the circulating nucleosomes if portal pressure significantly reduced. So genomic DNA released as a result of cell death is possible to target as a therapeutic in terms of modifying portal pressure by reducing the activation of stellate cells. So what is albumin? What's happening to albumin, which was initially thought to be a fluid, we think is a very important molecule involved in detoxification. And here we showed that the irreversibly destroyed form of albumin is significantly elevated in ACLF patients compared with controls. So HNA-A2, as you can see, is markedly high. So albumin is not only low in cirrhotic patients, but it's also dysfunctional. And Rita, while she was with us in London, had studied analbuminemic rats. And what she showed very nicely at the time was that if I knock out albumin, which is, these animals are okay to start with, but if you ligate the bile ducts, bile duct ligation, there's significantly greater death rate compared with those animals that are normal, suggesting that albumin is a very important protective molecule in this situation. So what I've shown you is albumin can bind DNA, it is destroyed in liver failure, and there are two big clinical trials that are being performed at the moment. This is just finished in Barcelona. We don't know the final results yet. The large trial in the UK, nearly 800 patients that will be included, called the ATTIRE study, in patients with AD and ACLF to see whether we can improve their survival. So first, translation, potential outcomes we'll see as we move forward. What about the PAMPs? This is LPS in the plasma. Is this important? Here are data from the US. Ramon Batalla, who is from Barcelona, did this study, and the data is still from Barcelona, and they show very nicely that a high LPS level in patients with acute alcoholic hepatitis and ACLF is associated with increased risk of death. The question is this possible to target? And we've been interested in a new molecule. It's called recombinant alkaline phosphatase. Alkaline phosphatase is produced by the liver, as you know, but it is, what alkaline phosphatase does is to dephosphorylate LPS. And so the question was whether this can protect from ACLF. And so what we did is to take this into animal models, sham LPS, BDL LPS, that's the LCA, that's a group with ACLF, with or without treatment with alkaline phosphatase. And we collected everything and we looked at it. This is the first thing. As you can see, if you administer LPS to a bile duct ligated animal, their ALT, marker of liver injury, goes up significantly. If you treat them with recombinant alkaline phosphatase, you significantly reduce the severity of liver injury in these animals. So recombinant alkaline phosphatase is entering into clinical trials as we speak. How does it work? What's interesting is that if you give LPS, the LPS levels are very high. But if I take the plasma from these animals and I incubate it with a toll-like receptor TLR4 reporter cell line, in the animals that are treated with alkaline phosphatase, there's really no signaling. Whereas in the control group here, as you can see, LPS animals have a high absorbance, suggesting that the TLR4 reporter cells are providing the impulse. But here, what you've done is essentially, although the LPS is there, it's neutralized in this situation. So alkaline phosphatase, we think, is a potential treatment for this situation. Here, looking at cell death, there is a BDL LPS animal. If you treat them with recombinant alkaline phosphatase, you significantly reduce injury. And this is using tunnel stain in this situation. What else can we do? We've been interested in toll-like receptor pathway. Here are the kidneys I promised to show you. They express increased amount of toll-like receptor 4 in the kidneys. And the question is whether treatment with a TLR4 antagonist is going to help. So this is looking at the gene expression. These are TLR4 related genes, both negatively and positively regulated. Increased TLR4 expression in the liver of ACLF patients. So we think that it is likely target of therapy. Here are some early data using TAC242, which is a toll-like receptor 4 antagonist. And the experimental situation here is a bile duct ligated animal that is treated with LPS or with TAC242. If you give them LPS, there's significant increase in liver injury, AST and ALT go up. If you treat them with TAC242 before, you can prevent this happening. You reduce the amount of TNF and IL-6 that has been secreted. And this data is being replicated in 2 other models now, and it is likely that a clinical trial in this situation will move forward as we move forward from here. So we think that TAC242 in this situation would be interesting to study. What about liver support? So I can't finish without acknowledging Rafa's huge contribution to extracorporeal liver support, albumin dialysis area. And all of you must know that Rafa led a big study of albumin dialysis in ACLF patients. And he found that this did not work. And this has really led to the design of a new study, new device which we have invented, which is based on the ideas that I've presented to you. Essentially, there are 2 filters. The first filter will take albumin out, bad albumin out. The second filter will take these DAMPs and PAMPs out. And we've been able to generate a machine. We got a big grant from the EU to test it in clinical trials, and we replace good albumin over there. That's what the machine looks like. Hopefully you have the first patient very soon. When? Yesterday? And this is what the data showed. These are an acute liver failure rather than acute and chronic liver failure. This is a combination of the 2 studies that we have described previously. If you treated these animals at the acute liver failure stages with the device, you can improve their survival. This is what the hypothesis is based on. You take out the nasties and see if the liver will recover. So, fingers crossed, we'll see. Is there hope in the future? And here are some data from India, which personally I think is too good to be true. This is using GCSF, granulocyte colony stimulating factor. As you can see here, the patients were treated either with placebo or with GCSF, and with a tiny number of patients, they show a massive improvement in survival. To me, this is, like I said, too good to be true, and I would like this to be tested. But the point is that it is likely that we will be able to start to answer this problem, and the authors hypothesize, there's no data, that this might help liver regeneration by producing or releasing bone marrow derived stem cells into the circulation. This is, I promise, my penultimate slide. What this is showing you is the number of possibilities there are to modify this very severe and complex syndrome. Targeting up here as prevention modes. We have another project from the EU which is trying to target bacterial translocation using a carbon that we have made. the TLR4 antagonists, you've heard about the albumin, GCSF. Targeted cytokine therapies, I think, are real. Liver support, and of course, targeting the organs as we move forward. There are 9 clinical trials which are being organized through the auspices of the European Foundation of Chronic Liver Failure Research, which is ongoing, starting from 0 in 2010, building up to real possibilities to identify, prognosticate, and possibly treat these patients. So just to conclude, Mr. Chairman, ACLF is indeed distinct form of acute decompensation. Pathophysiologically, I hope I've shown you that this syndrome is distinct from acute decompensation. There are many potential targets of therapy, and here there is an opportunity for us to together from various fields. I've heard this morning immunologists, I've heard nephrologists, and I've heard surgeons, basic scientists, and there's a role for all of us to play if you're going to solve this syndrome. And finally, I think I must acknowledge the European Foundation of CLIF, which is the umbrella organization which now is related to about 100 hospitals in Europe that are contributing data. People that fund my work, European Union has been very important. I'm in Britain and Brexit, you know, so it's going to be terrible. So if you have a job for me, I'll move here, so at least I have a chance. And of course, the most important people that have spent 10, 15 years in this journey with me over here, who have got me to this position, which I've described to you today. So thank you very much. Well, you know that there is a really important understanding in the role of sarcopenia in defining the outcome of patients. So we don't have good data on whether sarcopenia actually increases the mortality of these patients, but we know as a clinical fact that if your morbidity index is high, or if you're frail, you're more likely to die with the same syndrome. So I have no doubt at all that the severity of sarcopenia, which relates to directly to frailty or to your Charlson's morbidity index, will be an independent predictor of mortality. But this just needs to be shown. So I've described to you a route that we are taking. You know, we have taken a pragmatic approach, which is to modulate rather than inhibit. So you only want to try and get towards normality, what is abnormal. And I think in the future what we'll have is companion biomarkers that will further risk stratify patients in terms of what kind of intervention they should have. So we now start to generate banks with careful phenotyping of patients on a daily basis in order to detect as to what the patient is like. And I hope that you've seen during my talk that a patient changes during the course of the disease. They might, in the very early phases, they may be very pro-inflammatory, but in the later phases they may be immune incompetent. And so therefore the same approach in these two patients is unlikely to work. And so therefore I think that, you know, we will have biomarkers as we move forward that identify which patient is in what situation, but up until then we have to work with what we have, and the idea is to modulate the responses. So for example, if I take a toll-like receptor 4 antagonist in this model, I switch off both TNF and IL-10 production. All right, so that what I'm targeting is both the anti-inflammatory and the pro-inflammatory response. Now, you say then where does the resolution come from? So I don't know the answer. So I think, you know, this is like one step at a time, and I don't think that the answers are going to be easy. So, you know, remember that, you know, the syndrome is only defined 2 or 3 years ago. So all the papers that you look at combine all the patients with single time measurement of a single cell type. And that's why I think your work is so important, because you can look at all these cell phenotypes all at the same time from the functional perspective. But the challenge is to study them sequentially with careful phenotyping, to look at a relationship between immunotype and the phenotype, to start to make some sense for what's going on. I think this whole idea that we will create some bomb by studying single cells is gone. There is no more studies that should be done with single cell types, because it tells you nothing about regulation. And so I'm not sure I've answered your question, but the answer is, simple answer is no, we don't know yet. But there's opportunity, because it'll be the key to solving this problem in the future. So again, thank you for this question. So there are only two papers in the world, one from Rafa and one from ourselves, that showed that Mars reduces portal pressure acutely. So the paradigm is this, that when you're treating patients with ACLF with Mars, we see that you reduce portal pressure acutely within 8 to 10 hours. It's not possible to happen by altering the structure. The second study, so we did the same study, and it's been supported by Rafa's study, but we also did another study where we give these patients infliximab, and we measured the portal pressure, and we show that within 24 hours you can reduce the portal pressure with acute anti-inflammatory signal like infliximab. So it is almost certainly related to dynamic phenomena, which possibly is a consequence of cell death or inflammation, because you modulate both with these two interventions. Baby steps, what I've shown you is really the first baby step. The ACLF model we have is a poor model. So we are taking a cholestatic disease, which is bile duct ligation. We're hitting it with LPS, which is a really big sledgehammer. So I heard this morning about a great model, which is an alcoholic liver disease model with the Liber Decali diet, which I think should be the cirrhosis in the background with a second hit with LPS. But now we should have a second hit with genomic DNA. Why not have a second hit with gastrointestinal bleeding, or with shock, or with surgery, as long as you can control the amount and the way you administer it. So you're absolutely right. What we need to do is to create, let's say, NAFLD cirrhosis, and have different kinds of insult to see what is common and what is different, so that we can get to the root of the biology of the syndrome a little bit better, to answer whether one shoe will fit all, or do we need different strategies for different pyros, if you see what I mean. Back to the models, and the models, of course, are, as we have already discussed, need to be improved. I don't think that we have an adequate model, and so I think we can realistically now make NAFLD cirrhosis. What the second hit is needs to be standardized, and that's what we should do. And Jordi, as you already know, that models can only tell you about a particular fundamental pathophysiology that you're interested in. And initially we had made the bile duct ligated model with LPS to study the brain and the kidney. And in both these situations it gives us the perfect model that we are looking for, because it produces renal failure, it produces encephalopathy, the animal becomes comatose, and you see astrocytic swelling. But I think if you want to study liver disease, liver dysfunction and liver injury, I suspect that you need some more parenchymal liver disease, which is either with NAFLD, I think, or with CCL4, or, as we heard, with alcohol. So I think there's a lot of scope for improvement. And we should just take the same hits that we have in the human situation and put them into the animals. There's no reason why we can't introduce E. coli into the lung. So this is actually a pulmonary infection as opposed to giving them LPS. And then you can study them for 3 days to see what happens. So yep, it almost certainly will improve the situation. And so for this talk, I've limited my talk to cell death. But we also have a separate observation where we show that ammonia, which we know is elevated in patients with ACLF, can lead to increases in portal pressure by transducing stellate cells. And to answer your question, Jody, I think it is probably more than one hit. It is not only the product of cell death, but there may be other components that may be relevant in this story, including ammonia. So yeah, so everything to do.
Thank you, Rajiv. Many thanks for having you here. It has been really a pleasure to share the day with you. It has been a very exciting day, right? I think it was a great opportunity to share thinkings and to combine different fields that maybe can hopefully help us with this syndrome, yeah? So thanks everybody for coming, and thanks Barcelona for being there and for this initiative, yeah? See you in a month, yeah? Bye-bye. Bye.